All right. Welcome back, everybody. We're going to get things going on with the last couple of talks. The next speaker, you can all thank if you had a good time because nobody would be here without him. He was the person who introduced me to sports medicine, and I would not be a sports medicine doctor if he didn't exist. He was one of my mentors through med school and residency, and he's moved on, is now the director of the program in sports medicine and an assistant professor of family medicine and sports medicine at St. John's Family Medicine Residency in the University of Minnesota. He's a team physician for the Minnesota Gophers as well as for the Minnesota Twins and St. Paul Saints. So I'm going to turn things over to Rahul Kapur.
Great. Can you hear me?
Mhm.
Perfect. Let me share my screen. And there we are. Let's go. Good. See my slides? Yep.
Yep.
Okay, great. Okay. Thanks for the invitation. Um, Ben and Venkat. I was really excited to see the panel. Because I know Corey and I went to med school together. We are the same year grads at UVA, Wahoo, and Natasha was one of our fellows. So it's an outstanding panel and really fun for me to see my colleagues and kind of presenting on this stage and kind of showing all the amazing things that they have been doing. It's really fun. I have a really easy task, which is to cover primary care in 20 minutes, maybe 25 minutes. So I'm going to go really fast and just focus on a few topics. I'm going to go through my slides quickly. It is not intended for you to read them all in real time, but you'll have access to the slides later and really kind of broad guidelines and just kind of a general timeline. Ben, you should keep me on time in case I talk more than the allotted amount. Just pop up on the screen and tell me to stop talking. All right. Okay, here we go. So we're going to review some hypertension updates, a little sports derm primer, and then finish up with some GI, focus on treatment and return to play. And hopefully, if you do have questions, I can address them afterwards. Just a quick funny slide on blood pressure. Okay, so this is really important. Guidelines have been updated since about 2017 for pediatrics, and then a little bit after that. And the most important thing to notice in the guidelines is previously pre-hypertension was 120 to 139, and now that it's 120 to 129, meaning stage one is 130 to 139, and anything over a 140 systolic or 90 diastolic is actually considered stage two hypertension, and that could affect your workup and restriction from play. So we'll talk a little bit about that. PEDS guidelines, this is really important. These were revised in 2017. And so the board question is usually what are the three parameters we use for the nomogram for blood pressure? And it is age, gender, and height, not weight. But then what they noticed is when they were looking at the 95th percentile or 90th and 95th percentile, at around age 13, that mimicked the adult pressures. And so it's really simple. If you're seeing an athlete who is under 13, you still have to pull up the PEDS nomogram and figure out what percentile they are. But if it is over 13, then you're going to use the new adult guidelines. So again, pre-hypertension being 120 to 129 systolic, and then 130 to 139 stage one, and 140 over 90 is stage two. So just remember that for PEDS, important update. Okay, so what does this mean? So most of our data is old, and unfortunately, most of our guidelines use the old criteria. So I wish I had a new approach for you, but I was looking at the European guidelines, which have been updated in 2022, and they still use the old blood pressure cutoffs, not the newer ones. What happens when we look at blood pressure across sports? If you're an Olympic endurance athlete, you don't have hypertension. But if you're an Olympic weightlifter, I believe it was just one country study that showed it up to 83% of them had elevated blood pressure. So big problem in what are called static sports, and we'll highlight that. 2013 study on the NCAA, football was the highest, and specifically football linemen, if you wanted to look by position for blood pressure incidents. And then the NFL study had the same rate, which was increased in football. versus age-matched men in the general community. What happens when we apply the new guidelines? So then all of a sudden, if you are looking retrospectively at athletes, and I think Dresner and Harmon did the study in 2022 on 5,000 Pac-12 athletes, and when they applied the new guidelines, 35% of their athletes met the criteria for hypertension versus 9% with the old guidelines. And then same with kind of when you use athletes from age 13 to 35, you're talking about a significantly higher percentage now meet this criteria, and would warrant either a workup or possibly some consideration of restriction. So big impact on what we're doing. Now, it's contrary to what we would hope, right? Physical activity has been shown to decrease blood pressure. Even moderate intensity weightlifting is shown to decrease blood pressure. Hypertension in physically active people is 50% lower than the general population. Why do we screen for this if we think athletics is protective? Because adolescents who do have elevated blood pressure, 80% will go on to have hypertension as adults. And so if you, as a public health and pediatric kind of anticipatory guidance kind of model, you want to screen for this early and make interventions early to prevent later disease. This slide really highlights history and how important it is in our athletes. So you obviously want to talk about diet, and we do. You want to talk about sleep, substances, not only illicit substances, but performance-enhancing substances, prescription drugs, NSAIDs, caffeine pills, diet pills, and then other natural supplements. Really important to discuss when you're taking a history on somebody who has elevated blood pressure. How do we take our blood pressure? I would guarantee you that the majority of us do not take blood pressure following all these guidelines. The one that I looked at and just laughed at was no caffeine should be ingested during the hour preceding the reading. And I don't think I've ever asked a patient I've been attending for 18 years now, like when their last cup of coffee is. Half of my patients are drinking coffee while I see them, in the morning for their visits. So in the 5-minute thing, the way I get around that is the initial pressure before they're roomed is often high, and I'll always repeat it before they leave and find that it's significantly lower. But these are important things. Don't cross your legs. Use the right size cuff. Very important, especially when you're dealing with linemen with massive arms, to make sure that's actually a properly sized cuff. Try not to be talking. Things like that. So proper technique will lead to better measurement. And then home blood pressure monitoring has been shown to be as reliable, if not more, than that solitary pressure that you get in the office. But you want to have them bring in their cuff and make sure that it matches the numbers you're getting. And then also talk to them about technique, about not drinking coffee when they check their blood pressure, making sure they're seated for at least 5 minutes before they use their automated machine at home. So workup. For prehypertension or stage 1, my hope is that with most athletes, we are getting a screening EKG. Obviously, this is not a talk to discuss the evidence around that. But if you don't have an EKG and they do have high blood pressure, it would prompt you to get that. I always get a urinalysis just to make sure they don't have proteinuria or blood in their urine. And then I want to know what their kidney function is. Whether you get a lipid profile, I don't know if you're going to do much with that information, but it's recommended. For stage 2, you want to look for secondary causes. So sleep disorders, you want to do a retinal exam, and they may likely need an echo. And of course, if you're going to get an echo, make sure it's interpreted by somebody who has experience reading echoes for athletes, and consider hypertrophic cardiomyopathy. Okay, very busy slide, but the take home here is for stage 1, you're not going to limit their eligibility. For stage 2, if they are not controlled, you want to restrict them from high static sports. So weightlifting, boxing, wrestling, really important until their blood pressure is controlled. And that's whether they have end organ damage or not. And so those are somewhat updated guidelines. And then prehypertension should not be restricted. Some guidelines do say that everybody should have a screening echo that has elevated blood pressure. The newer European guidelines do not suggest that you have to have that unless there's evidence of end organ damage. So just something to remember in terms of return to play. This talks about static versus dynamic component sports. And so the most important thing is when you look up into the high static component sports, kind of the wrestling and bodybuilding and weightlifting, that's where you're going to restrict them. So practically speaking, when you're seeing your athletes and they have high blood pressure, they can do as much cardio as they want. You may need to restrict their lift until their blood pressure is controlled. So how are we going to control their blood pressure? Lifestyle, really important. To focus on, kind of like low salt diets. If stress is related, address those. NSAIDs is the big thing to make sure they're not chronically taking those. And of course, you're going to screen for steroids and other substances. And then if you're going to choose a med, this is always on sports boards. And you should know this for practice. ACEs and ARBs are preferred. And honestly, in clinical practice, we go to ARBs a lot more than ACEs, just so you don't have to go through the trouble of changing if they do get a cough. Obviously, cost is a factor, but losartan is often what we'll use first line. You can use calcium channel blockers for certain populations. Here's what you need to avoid. You need to avoid beta blockers and diuretics. And so this talks a little bit about potential side effects. I would tell you that overwhelmingly ACEs and ARBs are well controlled. Now the caveat there is if you're taking NSAIDs and you're on one of those drugs, you want to know about potential interactions. Why do we not use beta blockers and thiazides? Because many are banned. So in specific sports, beta blockers are banned. In all sports, thiazides are considered masking agents. Diuretics are, so they are banned. So don't get your athlete banned by doing first line HCTZ. All right, really important take home point. Okay, that was hypertension. Very quickly. So hopefully that was useful and didn't generate too many questions, just something to make sure that you're aware of. All right, we're going to jump into sports derm, which is really covering wrestling. That's Gable Stevenson. He is the #1 ranked heavyweight in the country, and like won an Olympic gold medal, and is just he will probably win the heavyweight again this year. Okay, so wrestlers, skin infections, let's jump right into it. The things that you need to know are what is considered adequately protected, what's considered properly covered, and if they are not able to be adequately protected or properly covered, that athlete needs to be disqualified. Really important, okay? But let's jump right into stuff. So strep and staph, so we're talking about impetigo, which is that honey-colored crust, and you see on that the patient's chin, and then the folliculitis, furuncles, carbuncles are just a continuum of kind of like the abscess boil continuum. So folliculitis, there's a picture up there, and then a furuncle is kind of like a boil, and then a carbuncle is a deep abscess. And these are most often strep and staph. What do you need to know about this besides, kind of knowing how to recognize them based on a picture? They need to be treated with oral antibiotics. And you could use for very local non-bullous disease mupirocin, but otherwise I would always go to orals. IND for abscesses, obviously you're going to try to do. So what are the requirements for wrestlers to wrestle if they have one of these skin infections? 72 hours of oral antibiotics, no draining lesions, no new lesions for 48 hours, needs to be able to be covered. This is for NCAA and high school. And you need to know this, 72 hours of oral antibiotics, nothing new for 48 hours. And I recommend reading this article if you're interested. So Andy Peterson is the doc over in Wisconsin, and then Iowa. Sorry, Andy. And BJ Anderson is actually one of the sports docs up here who works at Student Health, and BJ has published extensively on sports dermatology. And so, if you just kind of do a lit search on him and kind of wrestling or diseases in sports, this is where you're going to get your review articles that you need to know for both boards and practice. So this is just a table kind of summarizing options in terms of treatment for bacterial infections. Let's jump into HSV. Really important topic to know. Herpes gladiatorum incidence in wrestlers. BJ's study in 1999, 20 to 40%, as much as like 2/3 of these outbreaks during wrestling camps. What does it look like? So that's that grouped vesicles on an erythematous base. Really important for wrestlers to know that the most common location is going to be head or neck. versus the extremities and trunk. And so the vesicles, then you get erosions, then you get crusting. The lockup position for wrestling is really important. So if I'm a right-handed person, I'm going to grab my opponent's head with my right hand, bring their head to the right side of my face as I grapple, and that's where I'm going to get my lesions that I've contracted from them. So kind of knowing the mechanics of that are really important. Transmission is skin to skin. It's not from the mat. Primary infection. So this is a picture, the top picture is of a primary infection. There are more lesions in a primary infection. It's usually more symptomatic. They have some malaise, they have some headache, they may have lymphadenopathy and some fever. The second picture on the bottom is actually a recurrent infection. So less severe, less, of a prodrome. You may get some pain and tingling that lets you know, but obviously viral shedding is going to occur before the rash. So how do we diagnose it? I have honestly not unroofed, and I usually do this more clinically, but the technical answer is to look for a multinucleated giant cell on a Zank smear. You can also do cultures, but they can be problematic in terms of figuring out new versus old, kind of serum cultures. But just kind of talking about principles of HSV diagnosis. Why are we worried about it? I saw a wrestler last week whose face looked like the picture that I'm showing in the bottom right. And the thing that you need to notice here, and the top right kind of shows you, is that if they have a lesion that's on the tip of their nose, that's actually called a Hutchinson sign. And you have to remember that that's actually V1. And so if you have a V1 distribution HSV, that can affect your eye. And you can get herpes keratitis, which is what's shown in the fluorescent picture here. So wrestler looked like this. We got him an urgent opto eval that day to make sure he didn't have dendritic keratitis, which is this picture. All right, so really important if you have wrestlers, any involvement in this area, they need to see optostat because it could lead to blindness. Isolate, start oral antivirals, pending culture, and then to prevent epidemics, remove exposed athletes from practice or competition. Now, the 8 days is debatable, kind of depending on if it's your primary outbreak, secondary outbreak, high school versus college. We'll talk about that. Prophylaxis. Efficacy. So efficacy of valcyclovir works really well in terms of reducing kind of clearance time, and it also works really well for prophylaxis. So we try to get all of our wrestlers on Valtrex prophylaxis during the season. I would tell you the rate limiting step is them actually picking up the prescription. But we call it in for everybody, and they usually wait till they have an infection before they consider it, despite a lot of our counseling. So if they've never had a previous infection, you can prophylax at 500 a day. And then if they have, then it's a gram a day. And overall, wrestlers on Valtrex are 2.4 times less likely to have an outbreak. There's excellent data on this. It's well tolerated. It is generic. And I recommend it for anybody covering wrestling to encourage their team to be on Valtrex suppression. So this is a little table that kind of talks about treatment and prophylaxis. So, this is important. If it's a primary lesion and it's a high school athlete, they need 10 days of oral antivirals. And if it's recurrent, then it's 5 days, 120 hours before they could return. NCAA oral antivirals for 5 days, no new lesions for 3 days, no systemic symptoms. So you will get tested on this. You will be asked about this. 120 hours is the answer for HSV, which is why it's such a huge deal. People who are going to compete for the podium at like Big Tens and NCAAs will lose the opportunity to wrestle if they have an outbreak at the wrong time. Okay, quickly, tinea. So 2 most common fungal infections, Athleteid corporis and tinea pedis. Trichophyton tonsurans is the predominant fungus. Skin to skin contact. There's some debate about whether you can get it through mats. 2 great pictures here. So this is classic tinea corporis. You can see that kind of central clearing and that well demarcated border. On the right is a carrion or a boggy abscess that happens with tinea capitis. Often with patients, in this case, you'll have some posterior cervical lymphadenopathy, and that's more, that's the more severe version if you're going to get that. So tinea corporis, in the wrestlers, unlike it can still have a ring shape, but can have another shape. So this is a nice picture in wrestlers. This is in the scalp, and you're going to use oral antifungals overwhelmingly for a lot of this. Tinea pedis, and you can see some onychomycosis there. You can use topical antifungals for all of this. Oral antifungals are really the only way to clear onychomycosis. So for athletes, usually we'll go straight oral, or we can use oral topical combination. So what are the wrestling guidelines? Oral or topical treatment for 72 hours for tinea corporis, 14 days for tinea capitis, really important. And so this just kind of shows a table of the options. And then if they are prone to fungal infections, you can prophylax them with weekly fluconazole. But that's the quick and dirty on sports derm. So know the guidelines for bacterial infections, know the guidelines for herpes, know the guidelines for fungal infections. There's a ton of other diagnoses with sports derm, but for today, we're just covering those top three. Okay. All right. GI. Sorry, and that last one is a really nice summary table for you to look at. So it covers bacterial, herpes, and tinea. Okay, GI. So 30 to 70% of athletes will have some kind of GI disturbance. Most common sports are running, cycling, and weightlifting. This is interesting. So your symptom severity is inversely related to the fitness level or intensity, and then also the degree of fluid restriction that you're putting yourself through with the activities. My friend and colleague Jason Waterman and I wrote an article in 2012 on this, and then I found a new updated article on guidelines for this, and the first reference in it was our article, so I felt really good about that. So Jason and I are shocked that this is still being referenced as we wrote it early on in our careers, but really exciting to kind of see that like these things still hold true. Okay, so what's the pathophysiology? Mechanical forces, compression by the abdominal wall, the positioning of cyclists kind of crunches your abdomen for a prolonged period of time. There's increased sympathetic tone and altered GI hormones. And then the third most commonly known mechanism is you're basically shunting blood flow away from the gut and into the muscles and skin. It can this shunting effect is worsened with dehydration, but you can also cause a reperfusion injury when you stop, and you have this increased gut permeability, and that allows endotoxins to stimulate a cytokine release and then causes a lot of symptoms. So these are the three main categories of pathophysiology for GI pathology. Upper lower common things that you're going to see: gastric pain, heartburn, nausea, and vomiting. And then for lower, diarrhea, urgency, blood in the stool, and cramps. Increased need to defecate. A full stomach exacerbates most of these symptoms. When you're seeing an athlete with GI issues, what you really want to figure out are the GI issues related to the exercise in any way, or is this just uncovering an underlying systemic GI illness? All right. So what do you do with evaluation? You want to think about triggers. So foods, meds, supplements, change in athlete's training. What's the pattern of your pain? Is it actually impacting your performance? A dietary history is really important, kind of tracking meals, tracking hydration, fluid. And then do they have systemic symptoms or red flags, right? Are they losing weight? Do they have other systemic illness that you need to worry about? So when you're examining, obviously you want to do a comprehensive abdominal exam. And look for signs of a systemic illness. So they have wasting, or, is there, a rash associated? Is there lymphadenopathy? Is there joint pain associated? And then labs to consider, not for everybody, but just something to consider is I will usually get electrolytes and kidney function on everybody, and probably a sed rate just to see if it's something inflammatory. And then if I'm thinking about refractory heartburn or reflux, I'll check a stool H. pylori, and you can do other stool studies. So then dietary changes, food diary. So this is kind of principles of treatment: focus on hydration before, during, and after activity. Consider a trial of specific food elimination to see if that improves symptoms. And then these are important, just general principles: limit caffeine, limit carbs, try to stool before sports, limit solid foods to 3 hours prior to activity. And this is a really nice review table on kind of all of the things that you can see. So heartburn and reflux are very common. And then when you worry about gastritis, you want to think about H. pylori. The exercise-induced abdominal pain or a side stitch is very common. And the theory there is that it's due to a diaphragmatic spasm or peritoneal irritation. And then you can read the part about lower GI bleeds and diarrhea. I think I sped through that and I'm pretty much good. Ben, anybody with questions or anything that I need to address? And
All right. Thank you very much. That was
sure.
a great talk. And I know that when we were planning this, one of the things we wanted was, what do we as ER doctors not know? And you've done a good job. I know not all of primary care, but a good job giving
Yeah,
us a good summary for a starting point, especially with dealing with athletes.
yeah.
Um, don't see any specific
Great.
questions uh,
Um,
from the
for the
crowd, but
GI
I can,
talk, there was my timer. Good. The references here, this talk for this article by Nyla Coleman in 2019 is probably what I would look at. It's a really nice summary for GI.
yeah, people have asked. I am planning to send out or at least give access to the slides. So, things like this you can come back and look to look
Awesome.
at.
Great.
All right.
Greetings from
Thank you.
Minnesota.
Stay warm.
Yes. All right. And it was a pleasure. I hope the audience enjoyed it. And if you have any questions, feel free to reach out. And thanks, Ben.
Yeah, thank you.
Okay, great.